So the presentation depends on where it is. It's a painful syndrome. We usually say it's the syndrome of pain.
And then we find that the average age of diagnosis is 7 years.
And also painful intercourse. So it depends on where it is. It could be superficial or it could be deep in the abdomen when you're having intercourse. And interestingly, in some people, it's completely asymptomatic.
Yeah.
So it can just be coincidentally found when a doctor is doing a surgery for something else, and then you see endometriotic deposits.
The first question would be, what exactly is endometriosis? Welcome to the MedSquad Podcast. Now, this is part 2 of a conversation we've been having about PCOS and endometriosis. Now, we have dealt with PCOS. Now, let's look at endometriosis. And I have with me Dr. Mbuche and Dr. Flavia. And we are going to get into a deep dive in this. And once again, of course, I'm an outsider for obvious reasons. But this is something that, of course, has come to the forefront, especially in media, because of the late Njambi Kwekai, among other people who have been speaking about their experiences with endometriosis. So the first question would be, what exactly is endometriosis?
So endometriosis basically is a presence of endometrial tissue outside of the uterus. So endometrial tissue is what lines the inside of the uterus.
Mm-hmm.
So if it attaches itself and proliferates outside of where normally you would expect it to be,
Mm-hmm.
then that is endometriosis.
Yeah.
And the sites in which it can appear, it can literally go anywhere.
Mm.
So from the ovaries to the lining of the pelvis, which is called the peritoneum.
Yeah.
It can go to your intestines. It can go to your diaphragm. It can go to your lungs,
Yeah.
like was the case for Njambi.
Yeah.
It can go to your brain as well. And also it can go to the umbilicus,
Mm-hmm.
and it can go to scars. So for women who have had a cesarean section, or maybe they've had surgery for removal of uterine fibroids,
Yeah.
or even in some women when they get an episiotomy. So an episiotomy is a cut that's done in the perineum to just make it roomy for a vaginal delivery.
Mm-hmm.
So it can literally go anywhere.
Can go anywhere. So when you say the vaginal delivery, this is natural childbirth.
Yes.
And so that cut can also lead to,
Yes.
wow. So
Yes.
what are the symptoms, or how does it present, I guess? Because if it's going everywhere, wow.
Yes. So the presentation depends on where it is.
Mm-hmm.
It's a painful syndrome. We usually say it's the syndrome of pain. So if it's in your peritoneum, then you can present with chronic lower abdominal pain, even outside of menses.
Mm.
You just have this constant dull ache in your tummy that you really cannot explain. Another thing would be when you have very painful menses. So painful menses means menses that are preventing you from doing your daily activities. Like you're missing work or you're missing classes. You are literally bedbound when you're having your menses. That is abnormal. Or pain that is not responding to over-the-counter painkillers, to up to the point that maybe you have to go to the hospital to get an injection for that pain. Those are telltale signs that it could be endometriosis. And also painful intercourse. So it depends on where it is. It could be superficial or it could be deep in the abdomen when you're having intercourse. And also if it's, say, in the bladder, you can have some urinary symptoms. So you're getting bloody urine, you're having frequency of urine as well.
Yeah.
And then if it's in the rectum, you can have painful passage of stool, blood in the stool, constipation, diarrhea. So basically it presents according to where it is at. it is that.
And sometimes the symptoms are not specific. Someone can have gastrointestinal symptoms, like they can be vomiting, they can be diarrhea, they can be bloating, they can be nausea.
Yeah.
So,
wow. What is the statistical prevalence of endometriosis?
Okay. So maybe also to just backtrack it a bit, it would be important to mention menstrual irregularities as well as a symptom of endometriosis. So there are ladies who also have unpredictable bleeding, and infertility is also a very, very big thing. Someone might not know that they have endometriosis up to the point where they've been trying to get pregnant for a year, 2, 3, 5 years down the line, then they're diagnosed with endometriosis. And interestingly, in some people, it's completely asymptomatic. So it can just be coincidentally found when a doctor is doing a surgery for something else, and then you see endometriotic deposits. Now to come to the prevalence. In the world, generally endometriosis is mostly diagnosed between the ages of 25 and 35. The first time. The prevalence is about 10% maybe. But in women who are attending infertility clinics, the prevalence has been seen to be as high as 50%. And for women who have chronic pelvic pain, it's in excess of 70% as well. Yes. There's so the interesting bit is that in Africa, we don't have a lot of data on the prevalence of endometriosis in our population. There was this common misconception that the African woman didn't have risk factors for endometriosis because they were getting pregnant very early, having their first child at a very young age. And they spent most of their reproductive age being pregnant. But now with changes, with women chasing their careers, wanting to be directors and things like that, financial stability before having a first child, then the prevalence, of course, will go higher. There's an old study out of South Africa that placed the prevalence of endometriosis in Blacks at 2% and 7% for whites. But then there's a recent study, I think either from 2015 or 2018 out of Nigeria by Fowule that put the prevalence at 50%, among almost 50% in women who are undergoing laparoscopy.
Does race have a role to play in that, or it's just 50% in general, women who are undergoing laparoscopy?
It's in that population of women who are undergoing laparoscopy, not general reproductive age women. Yes.
Goodness. So, I mean, obviously there's I don't know if it's a stereotype or just something we keep hearing historically, that women or Black women, their pain is not taken seriously. They're believed to have a higher threshold for pain. So does this affect the access to treatment or management of the condition?
Yes, not only Black women, but usually period pain is looked at as normal. So someone comes and say they have dysmenorrhea, they're going to be given painkillers and sent back home. So that is affecting the diagnosis. And then we find that endometriosis, the average age of diagnosis is 7 years. So someone has lived with this condition for 7 years, and that's they're diagnosed after 7 years. Because of the symptoms, and then also the system.
Wow. So we will be getting to look at some of the symptoms, and also just from my own hearing, there's some similarities with something we've discussed before. We'll be right back to talk about that on the MedSquad podcast. Hey there! Welcome to Zuri Health HQ, where Africa's finest medical minds meet modern care. I'm Yafesi, your host on the MedSquad.
Here, care is personal. It's not just diagnosis, it's direction. From a cough to managing chronic illness, we listen and we lead.
Every symptom has a story. We listen, explain, and act together.
Nutrition is not just about food. It's fuel, it's healing, it's prevention. We help you eat with purpose for energy, for recovery, and for lifelong health.
We are not just lab coats, we are detectives, and your blood speaks when we translate.
Your mental health is not a luxury, it's your health, period. Whether it's trauma, depression, anxiety, or even wanting to speak to someone, we are here for you.
At Zuru Health, collaboration is our strongest prescription. We connect expertise across Africa to deliver care that is smart, affordable, and people first.
This is the MedSquad. Real conversations, real health, real people. From your inbox to your bedside, we're with you. Welcome back to the MedSquad Podcast as we discuss endometriosis, which is probably a familiar term to a lot of us, but we are not actually familiar with it, even though the term is familiar. And when you mentioned irregular menses and the issue of infertility, my mind went back to PCOS.
Mhm.
And so are they similar? And also the question is, can you have both at the same time?
So endometriosis and PCOS can have some similarities in presentation, like you rightfully said, the irregularity of menses. But the cause of the irregularity is what is different. So for PCOS, it has to do with the eutropic endometrium. By eutropic, I mean the normal endometrium. So the endometrium that's within the endometrial cavity, responding to these fluctuations in hormones. That's what causes the irregularity. For endometriosis, on the other side, it's because of ectopic endometrium. So ectopic endometrium means endometrium that's in a place where it's not supposed to be. That endometrium usually has a little bit of increased blood supply and things like that, and that can bring about the irregularity of the menses.
So is the body treating it like a foreign object, so it's like fighting against itself? Or you mentioned that it's not in a place it's supposed to be.
Not really. It's just that irregardless of where this endometrium is, the hormones are circulating throughout the body. So it will respond in the same way that eutropic endometrium would. So when you're having a period and this lady is bleeding, then even that endometrium that is outside of the endometrial cavity is also bleeding. So if that endometrial nodule is in the lung, that nodule is bleeding. So they might have some chest pain. They might even start coughing up blood. They can have blood accumulating in the lungs. They can get a spontaneous rupture, so to speak, of the lungs. Yes.
But also in some areas, like especially the abdominal area, where you find the endometrium tissue, there's the cases of inflammation and irritation causing scarring and formation of bands of tissue, which are called adhesions. So you find the colon, the intestine, is attached to the uterus. Then it causes more pain.
Wow. How is diagnosis carried out then? And what are there any barriers to diagnosis?
So diagnosis is usually mostly pegged on the clinical symptoms that the patient presents with and imaging as well. So we used to think before that the gold standard was for us to visually see the lesion through minimally invasive surgery. It's called laparoscopy, where you put a camera into the abdomen and you look. And if you see that there is a lesion, then you take that lesion and you take it to the lab, and the pathologist will confirm that indeed that is endometriosis. But now we are moving away from laparoscopy and saying that imaging modalities like ultrasound are just as good, especially for deeply infiltrating endometriosis. They are just as good in trained hands in diagnosing endometriosis. And then you've asked about the barriers to the diagnosis of endometriosis. Number one, there is the taboos and stigma that we talked about. So I don't talk about my period pain because my mother had period pain. So I think it's just a normal thing in the family. That's number one. And then number two, the lack of knowledge among healthcare providers as well. And then number three, there's the accessibility to diagnostic facilities. So for example, your MRIs or even your laparoscopy, it's not very widespread. So you might not have those facilities to diagnose. And then also the human resource and the specialization to, even after diagnosis, then to treat. Because for endometriosis especially, we usually say you have to get it right the first time, because when you go in there, it's a jungle. The anatomy is so distorted, so your doctor has to have very specialized skills to be able to operate on someone who has endometriosis. And it takes quite a bit of training to get to that level of proficiency. So we need to train more.
And there are not that many around.
Yes, not that many, not to that level of treatment of endometriosis. So maybe most gynecologists will have just basic training on doing diagnostic laparoscopies, but not treatment for endometriosis.
Is it because, you might have, say, your course outline, this is what I'm qualified for. So are the options available, and then I, as a gynecologist, choose to go further in the training? Or is it that I find it out on the job that we need to adapt to the prevalence of a certain condition?
So it starts from during training itself, that in some places you might not have the luxury of being exposed to some of these sophisticated things like laparoscopy. And you see also the training is only just for a certain number of years. You might not get enough caseload to be that proficient immediately after you leave school. So it's most of the time usually a personal initiative, either to go back to train or attach yourself to a surgeon who specializes in endometriosis surgery, so that you're building up on your caseload.
This is this is eye-opening, quite eye-opening. And well, when we come back, we'll be talking about living with endometriosis. We've talked about diagnosis and its prevalence, but what about living with it? Because I'm sure, personally, I can say I know people in my family who live with endometriosis. This is the MedSquad Podcast. We have candid conversations about health and wellness across Africa. We'll be back. Welcome back to the MedSquad Podcast. Dr. Mbuche and Dr. Flavia are giving me an education, and hopefully you're also receiving one. And I'll let you know what you can do with that education when we get to the end of this. But for now, as we talk about endometriosis, the question is, are there stages of progression? Because like for me, listening from the outside, it seems to be pain from the get-go. But are there stages of progression clinically?
But yes, there are stages of progression. Endometriosis has 4 stages. Stage 1, which is minimal stage, which is minimal. We have few and superficial implants of the endometrial tissue. And then there's stage 2, which is the mild form, where the deep implants of this tissue. And then there's stage 3, which is moderate. So here we're having deep implantation and then scar formation. And then we have stage 4, which is severe.
Yeah.
So we have deep implantation, scar formation involving most of the pelvic organs.
Yeah.
And then the thing about endometriosis is not about how severe the implants are. They can be all over the place, but the person is having minimal pain. And then another person can have very few implants and is in a lot of pain.
Yeah.
Yes.
So the symptoms don't seem, are they consistent across stages, or for some people they will express at different points or may not even express at all?
So like Dr. Flavia has rightfully said, the clinical stage sometimes does not correlate at all with the symptomatology. So you can have someone who's asymptomatic and you go in there and there are deep deposits.
Yeah.
Then you can have someone with very, very bad menstrual cramping and you go in there and it's just what we called powder gun deposits. So these are very, very superficial.
Yeah.
So the two are not correlated at all.
Okay.
Yes.
So then what is the long-term impact of endometriosis if you may not have symptoms, but when you go in you find this like really deep, we call it the deep
Endometriosis.
deep endometriosis.
Yes.
So let's take two cases. Someone who has been diagnosed and is on treatment, and then someone who is undiagnosed. What is the long-term impact on their health or their life?
Okay, so for those ones who've been diagnosed and they're on treatment, there would be implications on some of the pharmacological agents that we use for the treatment of these diseases. So, for example, there's a class of drugs called GnRH analogs where they put you in menopause. So for that group of people, they might experience that side effects of having either postmenopausal syndromes. So it affects their bone density. They will have mood swings. They'll have maybe dryness of the vagina. They might have insomnia and hot flashes. So it puts them in artificial menopause. That's number one. And then you can have patients who are on treatment, but then they are being undertreated. So there is this persistence of the disease. The problem, especially when it comes to pain with endometriosis, is that there is central sensitization of your neurons. So you can have treatment, but you're still in a lot of pain because even if the nodules are shrinking in size, your neurons, it's kind of like you're perceiving the pain from your brain. Those neurons have already been sensitized. So even sometimes with surgery, you're really unable to sort out the issue of pain. So there might be persistence of the symptoms even with the treatment. Yes, even with management, including surgery, especially pain. And then for the ones who are not diagnosed, of course, there are issues with infertility, and then the persistence of the pain and all the other symptoms, depending on where these nodules are, especially for nodules that are maybe encasing on the ureters. They might cause secondary complications like failure of the kidneys. And sometimes it can be fatal. Like you can imagine you have endometriosis in the brain. So you're getting, we call them catamenal seizures. That is, you're getting seizures during your menses because you're bleeding into the brain. Some of these things can be fatal.
Wow.
Yes.
Is there a cure for endometriosis?
So unfortunately, there is no cure for endometriosis at the moment. It's usually just a symptom relief. So some of the agents that we use include things like painkillers, might include things as simple as paracetamol to things that are a bit more sophisticated and stronger, like your NSAIDs and opioids as well. Yes. And then hormonal treatments, of course, from your combined oral contraceptive pills to progesterone-only pills. So nowadays, we've moved away from the combined pill. We are inclined more towards the progesterone-only pill because we get better symptom control, especially the irregularity of the menses. And the side effects are tolerated better. There's less untoward effects like androgenic effects, because some of these treatments can give you virilization. So you're getting hair growing in abnormal places because it raises the androgens. And we can also give the progesterone only pill for a bit longer without causing too much trouble.
So that's one of the side effects. So if I'm thinking, okay, just I thought some of the side effects in the treatment that you mentioned mimic some of the symptoms in like PCOS. So now that for me, I don't know, how is this managed for the patients? Like,
yes. So sometimes you can get hyperandrogenic effects. So an excess of male hormones with some of the management strategies. But like I said, now we have safer options. So before you get to that point where you have no choice but to give the drug that's going to give you androgenic effects, you start with what's safe.
okay.
Yes. So there's options. Now we have options.
Okay.
Yes.
Wow. So with regard to endometriosis, is there policy support? Is there government support or advocacy support? I don't know. How we do have a lot of people who are endometriosis warriors. They may call themselves that. I know someone like Elsie Wandera and a few others who are doing that. But is there enough support or advocacy?
The government should consider coming up with centers of excellence for treatment of endometriosis. So at the moment, I would consider the big facilities like Kenyatta National Hospital, the Aga Khan University Hospital, as well as centers of excellence. And then there are private institutions like the Third Park Hospital, Dr. John Jaggi and Dr. Yamal. They are doing a very good job with putting out information on social media. So that's a good place to start from.
How do you find that information? Do they hashtag it or?
So Dr. John Jaggi, I think his handles on the socials is just John Jaggi. So if you search for him on TikTok, you will find his surgeries. He actually does live recordings of his surgeries and broadcasts them. Wow. So that's very, very good. And I know he's also very big with advocacy in talking to young girls, going around schools, talking to them about menstrual health and these red flags that they can pick up from very, very early on. He also has it's called the African Center for Endometriosis in Kerugoya, and he's very big on CSR as well. So in collaboration with SEK, it's called Mount Kenya SEK Hospital. He does a lot of outreach work through his initiative of laparoscopy mashinani.
Oh, wow.
Yes.
That's really good.
So Kenyatta Hospital is coming up with an IVF center. So this is assisted reproduction because a very big burden of fertility issues is with the women who suffer from endometriosis. So I think that's a very good thing.
It is. In how long do you think it? Or have they said when it will be coming out?
Well, they've not said when it will be coming up because the when it will be finished rather. Usually the biggest thing is setting up the lab.
Yeah.
Yes. So they are coming up with the IVF center and a fellowship as well on endocrinology and fertility, so that they go hand in hand. And I think that's going to solve a big gap in training specialists. Yes.
The training aspect.
Yes.
Wow.
Yes.
So, hey, thank you so much for this information. Is there any parting shot you'd offer to, just any parting shot? Because I don't even know how to approach this.
I would say it's important for women to know their bodies, to know their menstrual cycle. And there you can know the abnormal and seek out help. And then if you go to hospital and you're not happy about it, like you say you have period pain and someone gives you painkillers and it's not a relief, it's okay to seek a second opinion. Be vocal about it. Fight for yourself. Fight for your rights. Yes, that's the only way we'll move forward from this.
Okay. Dr.
Yes. And then maybe I would pose this as a challenge to us as healthcare providers and specialists. We are big consumers of data, but we really do not produce the data. So I would challenge us as specialists to do the research, so that we come up with home-made solutions for our problems, for our local problems. Yes. And then for when you're approaching your patient, always a holistic approach, not just symptom treatment and really not addressing the root cause of the matter. So you have to look at the person as a whole, and multidisciplinary teams in management, especially for patients with endometriosis. Make sure you have, if you need a psychiatrist, you've involved a psychiatrist, a psychologist, nutritionist, specialist in pain management, fertility specialists as well. If you cannot sort a patient out, please always refer to the next.
Okay.
Yes.
Wow. If anything in this episode, and I know there's plenty that you found useful, please share it. Share it not just with someone, a lady you know who is going through this, but share it also with your brothers, your husband, the male influencers in your circles. Let them know about this. This is information we all need. This is the MedSquad Podcast. Follow us on @the MedSquad Pod on all our socials. Inbox us if there's anything you want us to address. And we'll see you next time.